Hello, everyone. Welcome to a special edition of the Final Friday webinar series. We're doing a first Friday this month, and we're really excited to have you all with us today and our speaker as well. So I'm just going to get to it. I'll add that there is a chat on the right that you are welcome to introduce yourself, say hi to everyone, and also ask questions that we'll be saving a lot of time at the end for. And the other thing that I will mention is just please try to, be nice to each other in the chat as always, and not offer each other medical advice, as we always say. We are all different, so please refrain from that. But otherwise, we're so thrilled to have you here today. So I'm just going to introduce our speaker and go from there. We have Dr. Sherene Shalhub with us, who is about to start her new position as the Chief of Vascular Surgery at OHSU, which is in Portland, Oregon. So we're so thrilled for her. And as I mentioned, she's a vascular surgeon, so her work focuses on treating patients with genetically triggered aortic diseases. And she's also a very active researcher working on research that impacts the medical management as well as surgical management of patients with aortic dissection. So she's going to talk today about her work as the primary principal investigator for the Patient-Centered Outcome Research Institute, and that's funded by that, PCORI, but the work is with the Aortic Dissection Collaborative. And this focuses on patient engagement for research and prioritization for aortic dissection. And she's also the PI for the Vascular Ehlers-Danlos Syndrome Research Collaborative, and has worked on lots and lots of research with us over the years. So we're really excited to also have her as a member of the John Ritter Foundation Professional Advisory Board. As you know from all the things I just mentioned, her work is very, very relevant to members of our community and everyone joining us on the call today. So we're thrilled to hear from her. And with that, I will turn myself off and turn the stage over to Dr. Shalhub.
Thank you, Ellen. And hi, everybody. And I love seeing all these comments in the chat already popping up from people from around the country and Canada too. Welcome. So thank you for being here. And as Ellen mentioned, I'm a vascular surgeon. So what I tell my patients is I'm a plumber. I deal with the aorta and the arteries coming off of that. And I'm really, my passion and my career has been dedicated to taking care of people with aortic dissections, and especially if they have genetic aortopathies. So I'm going to start sharing my screen here, and hopefully this will pop up for you to see. Do we see the screen? Yes, we do. All right. Great, thank you. So this talk may be a little bit different from the other talks that you've heard on this channel. And really my goal is to talk to you about the Aortic Dissection Collaborative and what we have done over the past few years. And so to give you an idea of how we're pursuing research in this space. And as you can see, my title here shows that I am at the University of Washington, which is where I have been for the last decade. And I'm here for the next 2 weeks before moving to Portland, as Ellen mentioned. Here are my disclosures. Really, this work is funded by the Patient-Centered Outcomes Research Institute, and I'll give you a little bit more about that. As you can see, in addition to serving on the John Ritter Foundation Advisory Board, I'm also on the Ehlers-Danlos Society and Marfan Foundation Advisory Boards, and there's really no financial conflicts of interest relevant to this talk. So here's what we'll talk about over the next hour or so. We'll talk about what is patient engagement, why patient engagement and aortic dissection research is crucial so we can advance that research. I'll talk about how did we pursue the engagement methodology and what the outcomes were and the lessons that we have learned. And then I will talk about sustainability and future directions. My goal, obviously, is I don't want to monopolize the entire hour. So I want to have room for discussion at the end. So please type in your questions in the chat as you think about things as they come along. And then really, I'd love to have your full self available to have a discussion at the end here. So in the space of aortic dissection research, there are several challenges that I've noticed and when I got into this, and predominantly is that everybody who's affected with aortic dissection is not the same, meaning that the population is heterogeneous. There's different reasons for why people have aortic dissections or different mutations and variants, and then there's just people who don't have any of the known genetic variants but have other causes as well. There's also different options for care, and that's because it depends on the anatomy of where the dissection happens. For example, a type A dissection versus type B dissection. But even within those areas, there are different treatment modalities, and we don't have long-term outcomes for an individual level. We have studies that look at populations, and we have aggregate data, but it's not necessarily individualized to the individual patient per se. And so that's one of the challenges in that area of research. And we truly believe that we have to bridge the gap between what we as researchers or clinicians think is important and what people living with aortic dissections think is important. You are the people living with aortic dissection. You are experts in your own condition. And so what you think is important is something that we have to address when we think about designing research. And that is the core of what patient engagement means. Meaning you are collaborators, not cases. So we are doing research with you as equitable research partners, not on you or for you as research subjects or cases, right? So this is where we want to build a community of people living with aortic dissections who can be our partners in research. Because as I said, you bring your expert voice. And I think to participate in a meaningful way, we have to level the playing field so that we are all sitting at the same table and talking in the same language so we are understanding each other. So this is why patient engagement in research is crucial. If you look at the traditional research model, these are researcher-centric, meaning me as a researcher, I will say, I think we should study X because I think X is important. And certainly when we do randomized trial or we do industry trials, we have to control the environment that we're picking the patients in and the way we're doing the treatment so we can standardize things in order to make the experiment work. But the problem with that is that it can limit generalizability, meaning it will only be applicable to a certain group of people, but not the entire group of patients. And also there may take a long time to implement the results that we find from these studies into clinical practice. Whereas when we engage patients in research, then we are addressing patients' research priorities. So we work with a patient population to identify what is important to them. And then we can design studies that are centered on what people think is important. And we do believe that that should improve research outcomes. It's also invaluable in rare disease research. So even though you are living with aortic dissections, in terms of the population at large, it's still considered relatively rare. And as you've experienced, many of you have experienced, when you have an aortic dissection, maybe people don't even know what an aorta is. When you say, I had an aortic dissection, the next question may be, well, what is an aorta? So as you can see, it is relatively rare. So as we build this research together, I think this is a great methodology. And what that looks like is it's a continuum. Engagement is a continuum. So you can start by informing people. You can say, hey, we're doing this research study. So that's just informing, right? It's not necessarily active engagement. Consulting is another way where you can have people or stakeholders offer opinions, advice, and feedback. But again, they're not true collaborators. Collaborators really decide together, they work together, they have joint decisions and joint actions. And ultimately, really a higher level of research would be stakeholder directed, meaning these are independent initiatives started by stakeholders. So for example, like if the John Ritter Foundation was to apply for a grant to do research, that's a great example of a stakeholder directed initiative. And then patient engagement also looks in different ways depending on where they're engaged in the research process. For example, if you're in from the ground level up in terms of agenda setting or preparation of the research project, that is one level of engagement. And then execution, can be participating in research, helping recruit other people into the research process, collecting data or analyzing data where we say, okay, here's what we found. What do you think? Are we right on? Are we right off? So on. And then translation. How do we send this information now into the clinical world and put it into patients' hands? And that leads me to PCORI. So PCORI is the Patient-Centered Outcomes Research Institute. It is in the United States. It was established in 2010 as part of the Patient Protection and Affordable Care Act. So this is a government-sponsored organization that really funds comparative clinical effectiveness research, meaning we're going to take treatment A and treatment B that are both being used in the community, and we're going to compare them head-to-head to see what works better. And the core of PCORI is patient engagement and the stakeholder involvement that I am talking about. And my personal approach to engagement strategy has been this tri-legged stool, where I think about patient researcher partnerships as a thing that is centered around building infrastructure, having education, and having cooperative relationships. And I'll talk a little bit more about what that means. But I do believe this improves the quality of the design, and over time should improve participant enrollment. And this is the methodology. We want to build, I'm going to go through all these boxes one by one, but we're going to build relationships, infrastructure, knowledge, and capacity. So what do I mean by relationships? This is, for example, an example of how we're building relationships with our community, that we are focused on research, prioritization, and design. And we have to start by finding stakeholders. And you can see there's some methodology in that area, such as method of convenience, meaning I've recruited patients that I have personally taken care of by talking to them, or, for example, by reaching out to people like Ellen and Meredith to say, are there people that you can help connect us with that may be interested in this work? We also advertise in the clinical departments to try to, again, reach out to other vascular surgeons or cardiac surgeons to say, are there people who would be interested? And then ask, if there are other people that are interested in participating. We've also used a lot of social media and connecting via National Patient Support Group or advocacy organizations. So John Ritter Foundation is a great example of that. And then social media via Facebook and Twitter and so on. Now, social media, while it is a great way to reach people, and it allows for quick dissemination of information, and these are already formed social support groups, we found that there are some limits, meaning not everybody uses social media. So certainly in that way, it doesn't represent all patients, right? It doesn't represent the patients who are not there. We've also used a lot of the virtual meeting spaces, and I'm highlighting Zoom, but this platform here that we're using now is another great example of virtual meeting spaces. And what's great about it is that it allows us to have these frequent meetings. It's efficient, it's cost effective. As I can see in the chat box, there are many of you from around the country and the world. So that's really fantastic. And then we've also found that it levels out the hierarchy, meaning one of the core tenets when we do this engagement work is that we are all sitting at this virtual table together, and we are leveling the playing field. So it's not doctor-patient, but it's more like Sherene, researcher, and patient John, who is living with aortic dissection. So everybody's bringing in their expertise in this leveled playing field. And we can also record it and make these recording available. So while many of you are joining us live today, many of you later on will be watching this at your convenience and not necessarily be able to join live, but it's still, the recording is available. It also, what was great, at least one of the silver linings that we have seen, despite the fact of COVID pandemic being such a devastating event, it has facilitated and catapulted this use of virtual meeting spaces. So a lot of people became more comfortable with the idea of coming in virtually and not necessarily have to get on a plane and travel to places. So these are all the advocacy and research organizations that we engaged with when we started doing this work. And you can see there's a lot of foundations and organizations that care about vascular disease or care about aortic dissection specifically, or care about genetic conditions that predispose to aortic dissections. And all of these organizations were represented in the Aortic Dissection Collaborative. And as I mentioned, we had to build these partnerships and do the co-learning together and perform these reciprocal relationships. So infrastructure, we had to create a governance structure where we had to create rules of engagement and how people want to participate. And we also wanted to create a virtual research network where we can reach out to people via social media to help answer surveys and questions. And this is what the governance structure looked like, is that we have an advisory group, and I'll show you who these people are. But these are the people that participate in strategic planning and guide survey development and interviews and so on. And then our stakeholder group initially started with 20 people, but really grew over time to over 90 people that have participated. I'll show you all the names, but basically they look at the materials and they, again, reach out to other people. And then the virtual research network, which probably some of you on here participate in, these are the people who responded to surveys or attended the webinars. And initially we started with maybe 200 people, but we grew to over 1,000 people on our mailing list, which has been phenomenal. And you can see here on the right-hand side, I'm showing you that the time commitment varies by where people are availability, because it's really important when we do this work is to meet people where they are. You may not have the time to do a whole lot of contribution, but you can certainly answer surveys, right, and have 10 minutes to answer a survey, and that's still valuable contribution. So this is, you can see our original advisory group that have been participated, myself as a researcher, Peter Byers as a researcher, Sarah Lawrence and Jenny Lee are our coordinators and qualitative researchers. And then we had Melanie Case, Navlet Cotter, and Timo Soderland and Deb Trotter. And oh my God, this is terrible that I'm blanking. Why am I blanking on this name? I'm blanking on my partner's name. This is terrible. I'm so sorry. But anyways, so this is our patient advisory group, and the name will come to me, so don't mind me. And you can see that, again, we wanted to evaluate the pre-existing patient-centered outcomes knowledge. Are they willing to participate in research? And that's part of the first things that we had to do. So we disseminated these surveys in 2020 to look at, this is a knock-knock, who's there? Are you interested? What's your experience with aortic dissection? I'll show you the results. And also, because COVID happened around that same time, it a little bit derailed some of the work that we were doing, but we pivoted quickly and included also questions about people's experiences with COVID. So here's some of the results. We asked, what was the most frustrating aspect of the aortic dissection diagnosis, and asked people to check all that apply. And you can see here, this was really eye-opening for us. So our original survey had only 434 responses, but you can see that, look at the top 3 things that were very important to people. Fear of death due to another acute aortic dissection or rupture, fear of needing another surgery or the possibility of that, needing surgery, and mental health, living with fear and depression and anxiety. And I will tell you, this is why engagement work is so important. When I went into this, these top 3 things were not on my radar of things that I wanted to study or think about. It's just that it wasn't part of what I was thinking about. And it took patient engagement to wake us up and say, oh my God, this is so important to people that we need to pay attention. Other things that were frustrating was, the decision making. As I mentioned, we have a lot of data, but it's not individualized to the individual to help them make those individualized decision making. Also, there was frustrations with emergency rooms maybe not being familiar with aortic dissections, and then you can see these other issues that brought up were important. We also asked which of these questions about aortic dissection are important to you. And these questions were created using the stakeholders and advisory groups' input. So they formulated some of these questions, and you can see they're grouped into genetics, surgery, and management. But for example, management was knowing what blood pressure I should be living with, how often do I need screening, what medications should I take, what's the best way to manage my disease. Surgery, centered around effectiveness of surgical techniques, what's the best type of surgery for my own aorta, and knowing when I need surgery. And then genetics, people wanted to know, how does this affect their family members, and what genetic testing should be done, and so on. The COVID Enhancement Award was additional funding, and again, it focused on the experience of people living with aortic dissections and how COVID-19 was impacting what's happening. And what we learned is that at that time, there was lack of clear guidance on how aortic health status contributes to COVID-19 risk. Was it a risk factor? If you remember, the CDC issued a warning saying that people with cardiac conditions are at increased risk, but really nobody knew where aortic dissections fit in. The other thing is, there was a lot of patient cancellations in terms of clinic cancellations on both sides, patients canceling clinic appointments and physicians canceling clinic appointments, because we all of a sudden went into this emergency type state. So now we've taken people who are living with complex aortic dissection and complex health conditions, but now they're navigating an even more complex healthcare system. And then telehealth became one of these things that we've discovered very quickly, that telehealth had a lot of advantages for people living with complex aortic disease, but not all telehealth was effective care. So we learned a lot from that as well. And now you can see, as we're continuing this work, we've identified now these bins of research topics that were identified as, the themes of research are important: education, genetics, medications, mental health, pregnancy, surgery, and telehealth. And so we took these bins and created teams that their job was to review the literature in those bins of topics. And this was a diverse group of people within these teams that included surgeons, physicians, medical students, and patient representation to address these landscape reviews. And this was their charge, was to look at what current research or initiatives have been conducted in these different areas, and then to identify gaps and opportunities. What questions haven't been answered? What are the topics that we can address quickly? Are there things that we can do that don't require giant trials that are very time intensive and very money intensive, but can we answer some of the questions with fewer resources? And then what questions lend themselves to comparative effectiveness research trial design and that need heavier resources to address? And we did this, you can see this was in May of last year to October of last year. So this was, went on between May and October. And the working groups had to come together and then not only work among themselves, but then come back to the stakeholder groups and present to the group. And then get feedback from the stakeholders on what they have done so far. Are they, and in terms of their interpretation of what the data that they were seeing. So the idea again here was not to create siloed thinking groups, because that can happen, right? When you have a group of people that are constantly working together, it can lead to siloed thinking. And we want to break down these siloed approaches. We want to have, again, diversity of thought and have different people participating in these ideas. And ultimately, we published this in the Seminars of Vascular Surgery. This was a dedicated journal issue specifically for all this work that we have done for the Aortic Dissection Collaborative. And one of the things we've done is also made it something called an open access, meaning any of you here on this call can go to this link and can download any of these papers that were published. So frequently in academic research, the journal articles may not be open access to people. So not everybody can, without an academic subscription, can access these journals. And what we wanted is we wanted the patient community at large, no matter at what level they are, to be able to pull up these articles and read them for themselves, so that they have access to the knowledge that we've accumulated so far. So you can see we've the only one that's not open access is my executive summary, which is just a 1.5 page summary of that, but everything else is open access. So the methods of how we've done it, we have this qualitative assessment of how people living with aortic dissection or at risk for aortic dissection, what their experiences look like. And you can see now all these other papers where we summarize the current medical assessment, we summarize the knowledge and surgical management in aortic dissection. We talked about how telemedicine can be implemented in aortic dissection. We also discussed genomic care in medicine and how that can lead to personalized care. We summarize the knowledge up to date in aortic dissection in pregnancy, as well as the stakeholder perspective on the state of education. And I see a lot of comments popping up in the box, but I bet you a lot of your comments will also focus on education and the need for education of both patients and healthcare providers on aortic dissection. And then we also summarize what we know to date on mental health impact in aortic dissection. So all these papers are, again, available to you, and you can look them up. So here's where we were. We started with identifying the community survey. We then had the community interviews, and then subsequently these working groups. And ultimately that led us to the research prioritization survey. So what that was is that we took the research questions that all these groups have identified and said, can we formulate comparative effectiveness research questions? Because again, PCORI wants to fund comparative effectiveness research, and we were able to come up with these particular questions. So I'm going to read those to you because I know they look small. So does having genetic testing improve the health or healthcare of people living with or at risk for aortic dissection? Would having the right educational resources about aortic dissections for patients and family members improve the health or healthcare of people with or at risk for aortic dissection? Would having the right educational resources about aortic dissections for doctors, like primary care providers or emergency doctors, improve the health or healthcare of patients with aortic dissection? What kind or how much exercise is safe and beneficial for people with aortic dissections or at risk for aortic dissection? And then for someone with aortic dissection, what is the right time to have surgery and when is okay to wait? And which medications are best for treatment for chronic aortic dissections? And would using telehealth visits and for certain doctor's appointments improve the healthcare of patients with aortic dissection? And what kind of mental health supports are most useful for people with or at risk for aortic dissection? So we deployed that survey between November 21 and February 2022. And here are the responses. We can see that we had 910 individuals from the United States and 200 individuals from outside the United States. And the most responses in the US were from Michigan, because Michigan is home for the International Registry of Aortic Dissection. So they have a long mailing list of people living with aortic dissections that are able to reach people that way. So you can see that the responses, we had 510 individuals living with aortic dissections responded, 349 individuals at risk, 132 family members, and 148 healthcare providers. The most of the healthcare providers that responded were vascular surgeons. And again, that shows you when you use social media, you can reach pretty much your ripple effect within your own group. So I'm a vascular surgeon, so I'm able to reach a lot of vascular surgeons, for example. And you can see here by mean score, meaning if you scored lower, that means it was the highest priority. So education for physicians was the highest priorities, and neck with that was genetic testing, followed by surgery, followed by education for patients. And then telehealth and mental health scored lower on that. Another way to look at this is we grouped it by top 3, meaning did you rank this research priority in your top 3? And you can see again among patients, this is all patients' responses. Education for physicians was very high, again followed by genetics and then surgery. And then here is the second column, the darker red, was by patients who don't. I was comparing patients with genetic conditions versus no genetic conditions to see if there's variability. There's some variability, but still a lot of consistency in terms of how education is so important. And then in terms of families, again, families felt that genetics and education for physicians was very important. And then this is an example of why it's important, again, to engage patients. So you can see physicians, healthcare providers, physicians ranked surgery questions as high on their priority list, right? So they're bringing in that perspective into research. We also asked people about willingness to participate in research. And this was very interesting because you can see the patients are here on the left and then the physicians on the right. So patients, we asked patients, would you be willing to participate in an observational study looking at TBAR? TBAR is the endovascular stent graft repair. So if you were to be offered a study in which you and your physician come up with your treatment, but we as researchers just want to observe and look at the results, would you be willing to participate? You can see that only 40% said yes. We also asked people, like, would you be willing to participate in a trial in which the treatment is chosen for you? So you don't choose a treatment, you just agree to participate in the trial, and then by a flip of coin, the treatment is chosen for you. This is called a randomized trial. And you can see that only 20% were willing to participate. Now compare that to physicians. So we asked physicians, would you be willing to approach your patients and ask them to participate in research in the thoracic endovascular repair treatment? Would you be willing to randomize them? You can see that almost 90% of physicians were willing to do that. So again, that shows you that there is a gap between how we as physicians or researchers approach research versus what people living with the conditions, how they think about participating in research. We've also learned that it's important, here are the lessons learned. We've learned that it's important to involve patient advocacy organizations early because they have the reach and the mailing list to touch base with patients. We have found that using social media and online searches is important to identify patient-led initiatives because that's important. We have learned the benefit of leveraging virtual research space or virtual meeting platforms to conduct these meetings, right? Because not everybody can get on a plane and show up physically. We've also learned that this is an iterative process, meaning every time we do this, every time we have a touch base, every time we have a talk, the diversity and number of participants increases with each iteration. And also, it is a tremendous opportunity that people can learn from what we've learned in the aortic dissection space to use that for other disease processes. So it doesn't have to be only for aortic dissection, it can be for other disease processes. And also it takes time. I mean, we started this work before COVID, and here we are 2+ years later, and you can see that that this takes time to build this kind of work. And this is, you know, when we publish it from an academic perspective, we summarize how this is an iterative process, that every time we do this, we increase more and more people that are interested in participating. So what are the next steps? What are we doing? Well, obviously, we want to submit patient-centered research proposals and projects. This is, again, the whole point of this work. And this is how we're collaborating and working with the John Ritter Foundation. And Meredith O'Neill will talk a little bit more about how the JR Foundation is helping fund the future steps in the Aortic Dissection Collaborative, because not only do we want to apply for research funding, but we want to continue having stakeholder meetings and patient advisory meetings, and we need that voice of the patients as we develop these research projects. So here we are now powered by the John Ritter Foundation Aortic Health. And this is, again, like how our collaborative strategic plan is involving. So you can see that this engagement work between 2019 and 2022 focused on finding it, the foundational work, gathering information, coming up with research priorities. But now we are in this proposed work where we're optimizing the work and wanting to understand patients' barriers and concerns to participating in research. We also want to identify, you know, when we say, for example, what is better for a patient, like is treatment A better than treatment B? What does that mean for people living with the disease? What does better look like for them? And then again, designing these trials in the future. These are the names of everybody, and Jake Howard is the one that I blanked out on his name, and I'm so sorry for doing that, but this is the name. You can see there's over 90 names here that people from different organizations and different patient populations have participated in this work today, and this is very important, again, from a diversity of thought perspective, because I don't want to sit there in a silo and just listen to myself talking. And with that, I am coming to a close. So this is the QR code that will take you to these articles that are freely available to you. And, I want to really now open the stage over the next half an hour that we have a discussion, and I want to hear your voices on this, what your thoughts are and what your questions are and so on. So thank you for your time and attention, and I'm going to stop sharing now.
Thank you so much for that. That was so interesting and different from the normal talks we have. So we've had a ton of engagement in the chat. Before I start talking about some of the questions and comments you all have, I did want to just introduce someone who you all know, the CEO of the John Ritter Foundation, Meredith O'Neill, and she's going to briefly talk about how the foundation is working and supporting the objectives of Dr. Shalhub's work and her experience also participating in the writing of those papers that were shared.
Well, hello. So good to see you. First of all, every time I get on these webinars, I'm always so excited. But particularly, I have a soft spot for Sherene. She is just so amazing, and the work that she is doing for patient-centered research is crucial. And just thank you, Sherene, for everything that you've done in this space as a not only person who works on aortic dissection professionally, but also personally as a patient. So that being said, how have I been involved in the Aortic Dissection Collaborative? I was approached by Sherene. She said, I really want you to be a part of this group. And I was honored and got to serve on the education stakeholder committee. And so this was talking kind of about how do we educate the physicians and why is that a priority to us? And we wrote a paper together. And what was really cool about it was not only did it have physicians, but it also had patients, not just here. We had a patient from England. We had a patient from Sweden. I wasn't the only one from America. We had a patient from Canada. And so it was really, really cool. We were all different ages. We were all different races. We were obviously all different genders. And to see that cross-section of patients was really, really exciting. And then watching us collaborate with the researchers and with the physicians, some of the things that we were telling physicians that were on our committee, it was truly watching a light bulb go off over their head. And you could see that the true collaboration was there. They were listening to us and all of that. And so we at the John Ritter Foundation, we have funded in a couple of different ways. We are very invested in the Aortic Dissection Collaborative, not only because I served on one of the committees, Ellen and I are also part of the stakeholders committee. And so we give our time, but also between PCORI funding, we were looking for bridge funding for the Aortic Dissection Collaborative. So we gave bridge funding to keep this going. We think it's extremely important. But also, last year, when we were looking at our strategic plan and our budget and our priorities, Ellen and I came together and we put out an all call for grant requests. And when we were thinking about the parameters of what kind of grants do we want to be funding with this $65,000 grant, we automatically went to what did the Aortic Dissection Collaborative say was a priority. And that's what we went out and we put parameters based on a couple of the priorities that the Aortic Dissection Collaborative had said were priorities. And we got a few back, and we got such great things that address mental health and exercise that we chose to find money within our budget to actually fund two. So we have two grants that have been funded from the John Ritter Foundation based on these priorities. So again, thank you, Sherene, for doing the work to ask the people, what do you really need, so that we could really make an impact on what people want.
Thank you. That's so exciting.
Ellen, yes. Ellen, did you want to add anything to that?
I will just add that one of the exercise focused one that Meredith mentioned, we have exciting news about that. I know a lot of you probably watched Dr. Prakash's webinar that he did with us. I will link it in the chat if you haven't seen it previously, where he talks about his work on exercise. But he is now enrolling patients in the clinical trial of exercise that we have funded, gave him as well as other investigators funding for. So you can enroll in that if you like, learn more about it. I'm going to put it up in just a second, the link to click on that. Anyone who has had a type A or type B dissection is potentially eligible. You do have to attend 2 in-person visits to either Houston, St. Louis, or Ann Arbor, University of Michigan. So we know that's limiting. Unfortunately, not everyone is close to one of those areas, but hopefully, if you're interested, you can make it to one of those spots. And they're enrolling patients for, I believe, the next 6 months in that. So please do share it with others who might be interested. If you have family members or, in your support groups on Facebook or whoever you participate. And hopefully some of you can participate in that, because I know that's a huge priority, as both I've heard from people and shown in the data. And with that, perhaps we should get to some discussion. Let me pick out the first ones here. So I'm going to put this up on the screen and we can discuss it as a group. So looks like this person says, I wish doctors would give a questionnaire or follow-up retrospectively on clinical signs that have resolved once the aortic dissection or aneurysm repaired. There's a lot of things that people talk about in groups, like being cold all the time. I have heard that. I've heard people talk about, are all these different things related, both the recovery immediately from surgery in terms of pain, especially. People are always concerned, is this pain from an incision? Am I having another dissection? Mm-hmm. What do you think about the idea of a follow-up questionnaire or for physicians who are following these patients post-surgery?
So I think this is actually, again, when we talk about eye-opening and light bulbs that happen when we talk to people, I had somebody yesterday in clinic who had an aortic dissection, and he did have his repair, and he did point out that he is cold all the time. And he said, why do you think I'm cold all the time? And I said, well, have you lost weight? And he's like, well, yeah, I've lost 20 pounds. And I said, well, probably related to the weight loss. But to be fair, now here's 2 days in a row where I'm hearing this question, right? So I think we didn't necessarily do this specifically, but maybe one of the things we should do is a survey with the patients to say, what are your questions that you're asking that you're never getting an answer for? Mm-hmm. And maybe collate that. So like if this particular question comes up over and over and over again, then maybe we on our side should go, that's so strange. Why do we think that is? I don't have a good explanation. I mean, my explanation for this particular person yesterday was that, you have lost a lot of weight, which means you've lost a lot of your padding. And so it's not unusual to feel cold when that happens. Mm-hmm. So I wonder if it's related to that. But I mean, I think this is an opportunity to ask those questions. Like I also, just my eyes kind of like running to this list of where somebody was asking about low platelets. where, and I have seen that, but I don't know what the literature says about that specifically. So I think we have an opportunity here again to say, what are the questions that are important to you that maybe you're just not getting an answer? Because you'll ask your physician and they'll be like, interesting, I don't know. Because a lot of times that'll happen, right? Where we'll be like, well, that's interesting, but I don't have a good answer for that.
Yeah. Yeah. And some of these things,
It's
quality
so-
of life, I mean, being cold all the time is unpleasant. It's not comfortable. So that could really.
It's interesting that you say that, because in one of the meetings that I had for Aortic Dissection Collaborative, we brought up ocular migraines. And you said, we should be doing research on that, since most of the patients on here was having ocular migraines and there's no research behind that. So again, getting these people together to talk about that, or again, the question around gallbladders, is a lot of people who have dissections end up having gallbladder surgery, but that's just word of mouth. That's literally just me hearing it from other people. So there's no science behind that. So, is that a question that people are interested in hearing? So it's just, that's why this stakeholders, and the more stakeholders we have and the more people who are telling us what's important to them will help us gather more data.
Absolutely.
Because the loudest voices sometimes are the only ones that are heard.
Right.
That's so true.
And I actually, I was thinking, and this is again feedback to the patient side. For example, from a researcher perspective, I don't have a way to go back in the charts. For example, we have this research that's called retrospective research. So what that means is that we go back into people's charts and collect data from the charts. And, the events already happened, things already happened, but we're able to collect things from the medical records. But being cold all the time, for example, will not be captured in the chart. Right? I mean, maybe it'll be mentioned in the note from the doctor saying, yes, they're cold, but I pretty much, I would guess it's not collected. So that's not something that we can collect via chart review. Now, the low platelets, for example, we can collect from chart review because that's lab work that's going to be in the medical records. So you can see there's different ways to approach how we can answer some of these questions. So that being cold all the time would be something that we'd have to send out a survey to people and say, have you felt cold all the time? Whereas the low platelets, we can say, oh, well, that's easy. We can just go back retrospectively and look at the charts and see if we're seeing low platelets frequently, or is it just that it happens that some people have low platelets, and as it happens, they also had a dissection, but maybe the true unrelated. I think they are related, but the only way to know is to answer it in a systematic way.
I'm pulling up this next one that I think is something that's actually quite on a lot of people's minds today about privacy and participating in research. And people have understandable concerns, especially when it's related to our genetic information. You hear all the time about data breaches and, you're getting the alert that someone's got your credit card number and stealing your identity. And of course, that is, I think, on every researcher's mind. No doctor or researcher wants to have patients feel unsafe or like their information is not being carefully guarded. I wonder if people brought this up at all as a reason, or you've thought about this as perhaps why people don't want to participate in research, is they think, they don't trust other people with their information, or they just don't know what the safety nets are there.
Right, and that's a very, very good point, and it's a big deal in research. So this is why we have something called an IRB, the Institutional Review Board. This is a group of people that look at the proposed study and say, what is the risk to the patients participating, and is it minimal risk, is it maximal risk, and what are we doing, what is the researcher doing to safeguard that data so that they don't end up in a breach. I will say that in our era of electronic medical records, we do see data breaches that happen. So our medical records are now living on servers everywhere. And you're hearing sometimes on the news, you'll hear things like where these hackers will hack into a healthcare system and hold it hostage, for example, and not allow people to get into their medical records, for example, which is horrible, right? But the point is the HIPAA and the protection of personal information is very high when it comes to electronic medical records, and that standard still applies to research. So for example, when we did our own surveys, we used something called REDCap. That is a HIPAA compliant electronic platform. So we're not using Google surveys, for example, which doesn't have the same level of stringent protections around how the data are served. And then all the data live on encrypted computers. So for example, my laptop, my work laptop, is an encrypted laptop. And there are rules around protecting my laptop. I'm never going to leave my laptop in my car unprotected or away from my site. It is constantly with me like an appendage, right? Because you don't want somebody to come swipe your laptop. But let's say somebody hypothetically was to knock me down and swipe my laptop. Even if they try to get into it, the laptop is encrypted. So they're not going to be able to get into it. And in general, I don't save any identifiable information on the laptop itself. So everything is living again on HIPAA compliant servers behind firewalls. So that again, there's multiple layers to protect that data so that we can protect against data breaches. And it's the highest standards, and we have to do it that way.
Absolutely. So hopefully, Louise, that gave you some info on that. But I encourage you to reach directly out to the I don't know if you're talking specifically about the John Ritter Research Program, but if you are, please reach out to them because they can give you all the details on that as well and talk to you about any concerns that you might have about your data security. Okay, and Sherene, you are also welcome if you see one that you want to pull out and talk about. There's a lot that I know we're not going to be able to get up to all of them. I apologize, but I'm trying to just grab some as we go. One person asked, and this is a great place to start to make sure we're all on the same page. What's the difference between an aneurysm and a dissection? So that's something we're probably starting every webinar with a little drawing maybe or something, but as you are an expert, I'm sure you can have a nice analogy for us or something to make sure we're all talking about this.
Why don't you look for another question? I'm going to quickly find some graphics to show this, answer that specific question.
Okay. And Meredith, I don't know if you see in here, but someone is asking about a few issues you've talked to me about. Are they related? Vision, eye-related things, which you've spoken about, and gallbladders, which I know you're passionate about understanding if that's somehow related to your dissection and your.
I don't know why I am so passionate about this, but for those of you who don't know my story, I actually am the 5th dissection in 4 generations for my family. And my mom had a dissection when she was 38. And guys, this is really exciting. And I wish she was on this webinar. On January 2nd, she will have been a 33-year survivor.
That's amazing.
Since her aortic dissection. And it is, I know I hear from a lot of people who fear. My mother, after she had her dissection, sorry, I'm going off on a little tangent, but she feared that, she always prayed, like, I'm the youngest of 3 girls. Let me just get to Meredith's graduation. Let me just get to Meredith's, college graduation. Let me just get to her wedding. And now here we are. I have a child, I live down the street from her and she's thriving. But everything that she has had basically throughout her entire life, I too have also had, including gallbladder surgery removal. And so, like I said, there is no science behind this yet. I'm interested in doing that. I think there are some other pressing things. And again, that's kind of like the loudest voice can be heard. I have to step back and say, but this isn't what the whole patient, nobody else is really talking about it. So let's put it a little lower down. But like Sherene said, we have this beautiful tool now that we can go out and say, which of these have you experienced post or pre-dissection, and how has it affected your life? How has it affected your quality of life? So I hear you. I'm always interested to hear what people's side effects are. My mom gets super cold all the time. That's the first time I've had somebody tell me that. That is not my problem. But yeah, that's fascinating. So thank you for sharing that with me, because again, this can also feel like a very lonely disease, because as Sherene said, that it's not rare to me, because I've had so many people in my family have aortic dissections, but in the true population, it is considered rare as of now. And so being a part of this group as well, another plug is it's cathartic, because you have other people who you have a shared experience with. And it's kind of like being a part of a club that you never wanted to join, but once you're there, you're glad there's other members. So I highly encourage all of you to join this group.
So I'm going to share just a slide to show some pictures, because it's easier to answer the question of what's a dissection and what's an aneurysm if you see it. And this is from an old slide deck that I used for Aortic Dissection Awareness Week for a different talk. But basically, I'm just showing here type B dissection, but really it's the idea of dissection. So when we say dissection, we're talking about that in the wall of the aorta, there is a tear, this intimal tear, as you can see right here, so where my arrow is moving. And the blood goes into between the layers of the wall and creates a false lumen. So if you look at it in this next slide, this picture in the middle. This is an intravascular ultrasound. This is an ultrasound probe that's inside the aorta, and the aorta, you can see it's like a tube, and you can see this layer right here. That is called the dissection. So that layer used to live on this wall and it's just moved over. So you can see on the picture on the right, there's a false lumen and a true lumen. So instead of it being one circle, it's a double barrel. So that's what a dissection looks like. Now that's a little different than aneurysm. So I'm going to just show you an aneurysm picture. If I can get to that slide. Right here. So an aneurysm is bulging, like when you have bulging of the aorta. So like an inner tube on a bicycle, tire where it sort of bulges out. And I think what's important to understand, I'm going to stop sharing because I show the pictures. What's important to understand is that you can have an aneurysm without a dissection. You can have a dissection in a normal aorta without an aneurysm. And when you have a dissection, there is a chance over time that weaker wall of the aorta will become an aneurysm. You can also have an aneurysm that later on has a dissection. So these are not mutually exclusive categories. And because of that, if you look at the old literature from the 50s, when people were beginning to describe dissections, because back then they didn't have CT scans, they were just doing angiograms, they talked about dissecting aneurysms. And really what they were talking about is that it was an aneurysm that then had a dissection. So a lot of times people with type A aortic dissection will have an aneurysm in the ascending aorta first and then have a dissection. This is why we talk about getting echoes and repairing the ascending aorta before it dissects. And we repair it when it reaches a certain size of aneurysm. But on the other hand, type B aortic dissections a lot of times happen in an aorta that is not an aneurysm. So then the dissection happens first, and then the wall is weak, and then over time it can become an aneurysm. So that is the difference between dissection and aneurysm. And so when you are talking with your doctor, ask them to be specific as to what do I have? Because again, the terms can be thrown interchangeably. And if you talk to somebody who's not a vascular surgeon or a cardiac surgeon, they may not even know the difference really. So now you are more educated than a lot of other people on what it means to have aneurysm and dissection and how the two can relate.
Thank you.
Can I ask a question?
Please.
Can you die from an aneurysm?
If it ruptures.
So what's the difference between a dissection and a
That's
rupture?
a good question. So I'm going to go back to your question. Can you die from an aneurysm? Yes, you can if it dissects or ruptures. So the rupture means that the wall, the outer layer is torn, and now the person is bleeding. So literally bleeding to death because the blood is no longer contained in the aorta. So that can cause death. And if the rupture happens anywhere in the aorta, it can lead to death. And frequently people talk about abdominal aortic rupture, for example, where people can have aneurysms in the abdominal aorta and it can rupture and they can bleed to death that way, or in the chest if it's an ascending aneurysm that ruptures. Dissection can also lead to death with or without rupture. So not all dissections will rupture. But if the dissection happens and it cuts off the blood flow, like that flap that I showed you, and it cuts off the blood flow to the arteries that are coming off. For example, it cuts off the blood flow to the carotid arteries going to the brain, or cuts off the blood flow to the coronary arteries that are feeding the heart, or the arteries that are feeding the intestines. That can also lead to death because these organs are now not getting the blood flow they're supposed to get.
That is so important because I think it's important for you to understand your own journey. I can't tell you how many people say my aorta ruptured and they just had a dissection because a dissection and a rupture are very different. And so I encourage all of you to know your story. And if you have any questions, reach out to us. Ellen and I are more than happy to talk through your story with you so that I know before I started working here, I told people that my mom had an aortic aneurysm. Well, she actually didn't have an aneurysm. She just had a dissection. We found that out through many years of looking through charts and all of that. And that's an important differentiator to my care team So it's just important to talk through that, not only for yourself, but for your first degree relatives.
And you can have a dissection with rupture, right? So people can say, I had a type A dissection with rupture. Absolutely, that can happen. But like you said, I think being specific in the language is important. And like I said, a lot of times even primary care doctors may just look at the notes and not realize that there are subtle differences in how that manifested.
And there was actually a question someone said about they don't even know what questions to ask their doctor, which I think is a universal feeling. I know, about any medical problem, if you're not knowledgeable, you don't necessarily know what things you should be asking. I did want to mention that we have also partnered with Mended Hearts, which is a peer-to-peer support organization. I know Maura, who's a research assistant, is on this. So if she could maybe Google and put a link for the Mended Hearts aortic dissection page. They actually have, a dissection guide that has some questions that you might think about asking your doctor as a starting point. Obviously, there's lots more and we're all different and unique, so you might have unique questions, but that's a good place to start. And what Meredith said about, tell me what my disease is. Did I have a dissection? Did I have a rupture? Ask them to draw you a picture. I know surgeons are really good at drawing the aorta, so they do it all day. So you have a right to know that info.
And they can show you your images. Ask them to show you your images, these CT scans. Our CT scans are so good now. They have 3-dimensional models of what your aorta looks like. So ask them to look at that.
That's a great suggestion. Similar to what we were just talking about, there's a bunch of questions that people are sort of asking about their own situation, saying my doctor won't do surgery, or they are waiting to 5.5 and I'm not comfortable with that, things like that. We don't have time to get into each one of these situations, unfortunately, but I wondered if maybe you could mention how important it is, or talk about your feelings about going to a multidisciplinary aortic center, or I know the guidelines have recently come out that are really emphasizing this. And basically, you're kind of right to a second opinion. Dr. Estrella joined us a few months ago and talked about a little bit about shared decision making. So I would love to hear your comments on that.
Yeah, I think it's important to ask. Let me paraphrase. Shared decision making is very important. You are a partner in this journey. This is your journey, and we as physicians, our job is to advise you and to take the data that as we know it and say, how do we adapt this to you specifically to come up with the best decision for you. And the way we view surgery is risk and benefit. And we always want to operate when the benefit outweighs the risk, right? Having a dead patient, having a dead person is not a good outcome, right? And so if that's the outcome and the risk is very high, then maybe surgery is not a good decision in that circumstance. But if we can do the surgery safely and successfully and help you get through it, then that is a good decision. You as a person living with this condition, I encourage you to learn as much as you can about it and be an expert in your own care. And certainly if you are not comfortable with the answers you're getting, you absolutely can get a second opinion. And multidisciplinary care is super important. And particularly in the big academic centers, that is the model. It's a standard where, we have cardiologists and geneticists and cardiac surgeons and vascular surgeons all working together to come with the right decision for that patient, or the best choice for that patient, I should say. There's no right or wrong answer, right? Ultimately, it's your choice into what you do with this information and what decisions you make that are good for you and your family. But like, for example, I see a comment that says, I don't think I should wait. Okay, well then I think you need to have a conversation with your physician about how you feel about this and ask for a second opinion. Your physician knows other people. We're all connected in these academic communities. And I encourage people to talk to other physicians and get second opinions. And telemedicine makes it also easy, right? Where I can talk to people who don't necessarily live in Washington, and maybe I can't practice medicine outside of my state, but I can certainly give you general information and that you can take back and help you, facilitate those conversations, or you can reach to other people who are living with the condition. The last thing I was going to say about saying, even if you don't know what questions to ask, a fair question to say, what questions should I ask you that I haven't asked? You can even end the conversation by saying at this session, say, what else should I ask you, doctor? What else should I ask you? Maybe I don't know what to ask, but what else should I ask you? And that's a good primer for them to say, oh, well, people usually ask about XYZ.
I love that as a question. We should add that to the official guidelines. We did a.
Yeah.
Sorry, go ahead.
Sorry, real quick to that. So you don't get offended when someone goes and asks a second
Absolutely
opinion, do
not.
you? I think that's a big missed opportunity a lot of people do, is because they're like, well, I love my doctor. I don't want them to think I don't trust them. It's not that. You're just getting a second opinion. The doctors are not offended. And if they are, maybe it's
I
not the right
agree 100% with that statement, because you need knowledge, and knowledge is power. And the way you get knowledge is by talking to physicians. And maybe, like I said, if something is not resonating with you for whatever reason, it doesn't matter. Like it's not a moral judgment, right? It's just, it's not sitting right with you. Then find ways to get the information you need so that when you make a decision, you are comfortable in your own decision.
Fantastic. We will get that added to our guideline for sure about, I don't know, kind of a patient rights sort of statement of these are what you can do, and you're not going to offend anyone or make anyone upset. I see a lot of people commenting on this in the chat, and someone can be a great surgeon, but maybe not the right one for you, and that's absolutely okay. We are hitting the hour here, so we have to let Dr. Shalhub go, because as you can see from her background, she is packing up for her big new job in Portland, Oregon, which we're so excited for her. There have been a lot of handouts and buttons and all this in the chat that I've shared with you all based on what we've talked about. If you missed one, just send an email to us at info@johnritter.com, or sorry, johnritterfoundation.org. I put it in the chat there, and we can and share those resources with you. Someone did ask about the last slide with all the names on it, Sherene. So if you are willing to share that slide so people can see all the names, if you want to email it to me, I can add it to
Yep. And actually, all you have to do is, if you want, just make the link to the journal, because it's all in there.
Fantastic. I think we did have a link in the chat, but if you didn't get it as it was going by, because I know lots of people were in there, then again, just reach out and we're happy to share all those resources. And then the last thing I'll say is we're really excited. Next week, we're going to be sharing a survey from the John Ritter Foundation that asks our community to hear feedback about how you enjoy these webinars. Is there something we can do to improve? What topics are you interested in hearing about from the future? Did you attend any of our aortic dissection awareness events? What did you like or not like about those? So we really encourage you to participate in this survey. It's less than 10 minutes. It's anonymous. We take all feedback, good and bad. So we want to have offerings that actually are helping and serving your needs. So please, if you have 7 minutes to complete this, we would really, really value your feedback. And we're going to use what you say to build our programming for next year. So it's really going to influence the experts we ask to join us and the other things that we're going to be offering to you all. Meredith, anything you want to add before we end it here?
I just want to thank Dr. Shalhub, Sherene again. Sherene, you're so wonderful. We are so lucky that I just get to pick up the phone and call one of the top vascular surgeons in the country to just say, hey, I have a question. And you're so willing to share your expertise, and the most valuable asset you have, your time with us. So grateful to you. And also, Ellen, I must say, you have done an excellent job on these this year. I know it's our last one of the year. So well done. I know this is your first year in this position. But thank you again for all your hard work.
It's been great.
I want to say thank you to both of you, both to Meredith and Ellen, because I think you're phenomenal, and I appreciate everything that you do in your time. And I appreciate all the warm wishes in the chat box. And thank you for being such a great audience and participating. And hopefully we'll cross paths soon.
Yes, absolutely. We will have a January event, but we weren't having one in December just because that's holiday time and everyone's quite busy, but we'll be back next year. So thanks again, everyone, and we will see you then. Take care.
Happy holidays,
Bye.
everyone.
Bye-bye.
Bye.